So Andrew, are you going to go next?
Yes, that sounds good.
Perfect. Go take it away, Andrew
Thank you.
and Kyla.
Hi, everyone. My name is Andrew Matias, and I will be presenting this with my teammate Kayla. And our project was on insights into obstructive sleep apnea amongst Native Hawaiian Pacific Islanders on the islands. And we actually didn't look just at Native Hawaiian Pacific Islanders. We looked at different populations that are common here, so Asian, white, etc. And we decided to focus on Native Hawaiian Pacific Islanders in particular just due to the lack of current research that there is on obstructive sleep apnea in particular. So we thought that given Hawaii has such a large amount, I believe it's almost a quarter of individuals here identify as Native Hawaiian or Pacific Islander, it's a great opportunity for us to explore this topic a bit further. So we did find some findings that did agree with current literature out there, such as obstructive sleep apnea is linked to obesity, particularly BMI rates. There was a positive correlation. But we also found some things that were not that were novel according to the current research out there. So what we found was that Native Hawaiian Pacific Islanders actually demonstrate a better adherence according to their peers. So a lot of research out there finds that a lot of minority groups demonstrate not as optimal adherence in comparison to their peers. But we found that Native Hawaiian Pacific Islanders actually did demonstrate better adherence to PAP therapy as the obstructive sleep apnea worsened. So we decided to look a little bit into that. Particularly, we looked into socioeconomic variables, classic ones such as household size, or we looked at education levels, we looked at median household income, but we weren't able to establish any strong correlations or anything significant there. So we decided to look a bit more into the social cultural side. So my teammate Caleb will explain a little bit more about the social cultural hypotheses that we developed from looking at that.
Thank you, Andrew. So like Andrew was saying, we tried to look for socioeconomic factors that would account for why NHPI patients in Hawaii demonstrated higher CPAP adherence rates than their peers, but there weren't much correlation. So this prompted us to consider sociocultural factors, specifically how cultural and familial dynamics might influence adherence in ways that economic data alone couldn't explain. So, Hawaii's housing landscape actually offers a unique context for considering how family support influences healthcare adherence. With housing and utility costs being sky high, it's really no surprise that Hawaii has the highest rate of multi-generational households at 15.7%. Furthermore, NHPI make up the largest share of this pie. Beyond cost sharing advantage to that, these living arrangements can also provide crucial social and health benefits. With multi-generational households, family members can share caregiving responsibilities, such as providing transportation, managing appointments, and even reinforcing treatment adherence. And I think this creates a potential adherence advantage in Hawaii's NHPI patients, which is one that may not be as prevalent elsewhere. And by that, I mean our studies show that NHPI populations showed increased adherence, but studies such as in Utah and New Zealand actually found the opposite, where NHPI populations had lower CPAP adherence. Our reasoning for that is one, the composition of NHPIs in places like New Zealand is more Maori, whereas in Hawaii it's Hawaiian. And another explanation could be that migration-related stress and weakened family ties could disrupt the support systems that are more intact in Hawaii. So again, this supports that family dynamics may strengthen social support, encourage shared decision making, and reduce stigma and logistical barriers to care. Next slide. While socioeconomic disadvantages are often associated with lower adherence rates, our findings challenge that in the NHPI population. So we asked, could strong family networks be a critical factor in supporting CPAP adherence? Research supports this idea. In 2022, a study by Khan and colleagues showed that structured caregiver engagement significantly improved CPAP adherence in newly diagnosed OSA patients. Similarly, in 2020, there was a study by Shu and others, and it found greater family support correlates with higher CPAP self-efficacy and outcome expectations. And although these studies didn't specifically examine the NHPI populations, they provide a compelling framework for our findings. Given that Hawaii has a high prevalence of multi-generational households, in addition with just general cultural things like in Hawaiian culture, ohana or family, and then kuleana and responsibility is important. And it's possible that these similar dynamics could be contributing to the higher adherence rates that we observed in the NHPI populations. Slide.
Thank you, Kayla. So that was the sociocultural hypothesis that we arrived at. And I'll just get a little bit more into the nitty-gritty of the actual design that we did in order to arrive to that conclusion. And we split it basically into three phases. So initially, what we found were a bunch of descriptive factors, but thanks to the guidance of our PIs, Dr. Karzana and Dr. Liao, we decided to use comparators as groups as well and analyze the statistical difference between those groups in order to arrive at a more comparative conclusion. So we had 340 sample patients from Hawaii Pacific Neuroscience's accredited sleep center, and it was about an even split, a little bit more Asian, but we had NHPI, Asian, and white groups as the comparators. And so next slide, please. So as mentioned, we had three phases. The first phase, we split it between BMI and AHI severity. So AHI severity is the apnea-hypopnea index. It's essentially just a proxy for how severe the obstructive sleep apnea is. So higher score means a more severe sleep apnea. So we found that BMI is a consistent predictor regardless of ethno-racial background. There was no statistical significance between those slopes that we performed. So we did a regression analysis between each ethno-racial group, and there was no significance between them. So this was interesting because it showed that BMI could be a reliable predictor of HI severity, and it also highlights the importance of perhaps targeted treatment at the obesity side, which because a lot of Native Hawaiian Pacific Islanders did present with higher BMIs, so as a result, they did have a lot of a higher obesity rate and obstructive sleep apnea severity. So if we can target it at the obesity rate, then we could have promising results given that they have the same relationship as their peers. So that was the first step. And the second step was very similar. Next slide, please. So similar methodology, but we did the AHI severity and adherence. So from here, we also found something that agrees with common literature. So the higher the severity of obstructive sleep apnea, the more adherent individuals do tend to be. That's just due to likely the therapeutic benefit of adhering more due to lessen the worsened symptoms. But we also found something, and this is where the novel finding was. We found that even though all groups did demonstrate a positive correlation between the severity of obstructive sleep apnea and adherence, Native Hawaiian Pacific Islanders had a notably more improved adherence compared to their peers. So as you folks can see, that dotted line, the steepest slope one, that is the Native Hawaiian Pacific Islander slope. And then we have the other groups as well with white individuals still demonstrating a positive slope, but it's the least pronounced. So this is where we started to think this is really interesting. This goes against common literature and findings out there. There were two other studies done amongst Native Hawaiian Pacific Islanders, but they were done in Utah, and the other one was done in New Zealand. But there was actually no comparative ones done in Hawaii. So we thought that this might be something interesting. Let's look a bit more into the socioeconomic variables. We'll see if we can find something that explains that. So next slide, please. So when we did look at the socioeconomic variables, we pulled it from the US Census Bureau, and then we also segregated it by zip code and based on the population in that zip code according to each ethno-racial group. And what was interesting is we found that there was no really significant correlations between a lot of the commonly predictable variables due to adherence. So median income, poverty rate, employment, education, etc. We did find one small correlation between the employment rate. So it was actually an inverse. So higher employment rate actually had a bit worse adherence. We looked at the literature for this. There were some studies that confirmed this. There were some studies that didn't confirm this. So we decided to keep that on the side for now. Perhaps that's just a spurious finding that we found. But in addition, we decided that since there was no real difference between the high income zip codes or the lower income zip codes, even amongst the same ethno-racial group, we decided that the sociocultural hypothesis would be something worth exploring. Next slide, please.
Yeah, so in summary, BMI consistently predicted OSA severity across all groups. NHPI had the highest severity at diagnosis, likely due to a higher BMI upon presentation. Although all ethno-racial groups demonstrated a positive correlation between OSA severity and adherence, NHPI patients demonstrated stronger adherence than their peers. But this was not adequately explained with the socioeconomic variables that we examined, which led us to suggest sociocultural factors might play a larger role. What this means, we think for clinicians, we do acknowledge that more research needs to be put into this to fully understand the patterns. But first, rather than focusing solely on clinical data, it's important to also recognize the broader cultural and familial context surrounding NHPI patients. Understanding how extended families, cultural obligations, and community networks influence daily life can provide valuable insights into potential barriers and motivators for CPAP adherence. Second, we should be cautious about applying adherence assumptions drawn from mainland or broad minority populations, as it may not apply directly to the patients in Hawaii. As a majority state, Hawaii has a unique cultural landscape, and the local NHPI patients may have different experiences and support systems compared to NHPI communities found elsewhere. And lastly, these observations suggest that family involvement could be an underutilized asset in OSA management. Clinicians might consider more intentional engagement of family members through caregiver education. Moving forward, more qualitative research is needed to explore how NHPI families in Hawaii navigate CPAP adherence and how these dynamics can be integrated into culturally tailored interventions. By moving away from this one-size-fits-all approach and developing more targeted strategies, we might uncover new pathways to enhance adherence and improve outcomes for the NHPI patients with obstructive sleep apnea. I think that's it. Thank you.
Go for it, Sarah.
All right. Hello, everyone. My name is Sarah. Last summer, I had the pleasure of leading a team of undergraduate interns and conducting some research. And one of our stellar interns, Sophia, will be presenting our work today. She actually just recently took her MCAT, which is a major hurdle in medical education. So now she's doing this. Can't wait to see what she does in the future. So take it away, Sophia.
Hi, everyone. So again, my name is Sophia, and today we'll be presenting a study entitled A Multiple Sclerosis Pilot Study, Are There Differences in Spinal Cord Involvement Among the Ethnocultural Groups of Hawaii? Next slide, please. So as you know, multiple sclerosis, or MS, is an autoimmune inflammatory disorder of the central nervous system that produces demyelinating white matter lesions disseminated in time and space. So clinically, MS most often presents with sensory or motor symptoms, but up to 50% of patients develop depression, many experience mood disorders, and a smaller subset can even present with psychosis. So therefore, early recognition of those at risk for neuropsychiatric comorbidity can profoundly affect the quality of life and long-term outcomes. So what piqued our interest into doing this study is that there is research to suggest that when spinal cord imaging is done at initial presentation, the burden of lesions may actually be able to predict the future disability level. So given that we're in Hawaii with an ethnoculturally diverse population, we're wondering if brain and spinal imaging at initial presentation may correlate with disability severity. And because we're already collecting data on all of this, we decided to also look into the demographics to compare comorbidities across these different groups. Next slide, please. So to do this, we conducted a retrospective chart review of the Hawaii Pacific Neuroscience database of all MS patients from 2008 to 2023, adults above 18 years old. And we collected the demographics, comorbidities, lesion burden, and location on both brain and spine MRI, and the presenting expanded disability status scale score, which we'll refer to as the EDSS score. And this score was assigned by a single one of our team members to ensure uniform scoring across all of these patients. Next slide, please. So going into results, this data was stratified into 6 groups: Caucasian, Hispanic, Asian, Black, Native Hawaiian, and other Pacific Islander, which we'll refer to as NHOPI and other. And something to note here is that one of our primary limitations is that our subgroup sizes, particularly the NHOPI group, are very small, which limits the statistical power of these comparisons. But overall, we had 128 patients total, majority being female. In our spine MRI group, we had 68 patients, majority being Caucasian. And then in our brain MRI group, we had 67 patients total, and then the majority were also Caucasian. And then this figure on the bottom here shows the age at initial presentation stratified by ethnocultural group. And after post-hoc analysis, we found that Caucasians were significantly older at presentation than the Hispanic group. Next slide, please. And across the full cohort, a few common medical comorbidities included hypertension, hypercholesterolemia, migraines, smoking status, and having an overweight BMI. And then a few of the psychiatric comorbidities were depression, anxiety, and bipolar disorder. However, we saw no significant differences in any of these comorbidities across all of the ethnocultural groups. Next slide, please. We next looked to see if there were any differences in disability status score across these groups at presentation. So this figure shows the presenting EDSS score of each ethnocultural group. And after post-hoc analysis, we found that the NHOPI patients had a significantly higher EDSS at presentation compared to the Hispanic group. Next slide, please. And when we looked at lesion burden on spine and brain MRI, overall, there were no significant differences across the ethnoculture groups. However, we did find some differences overall comparing EDSS versus the number of spinal lesions. So looking at this bottom left graph, when we compared patients with 2 or more spinal lesions to those with exactly 1, the group with 2 or more lesions had a significantly higher EDSS at presentation. And then the bottom right graph shows the number of brain lesions versus the EDSS score, which show no significant differences in the amount of brain lesions and the presenting EDSS score. Next slide, please. So to conclude, we saw no race-based differences in overall spinal or brain lesion burden, but 2 notable exceptions were that Caucasians presented significantly older than the Hispanic group, and the NHOPI group had higher EDSS scores at presentation than the Hispanic group. Genetic factors may underlie the differential age of onset or lesion susceptibility in these groups. And additionally, socioeconomic and historical factors could delay diagnosis or treatment, leading to higher disability at the first visit. In the future, we definitely want to expand our sample size, particularly among the NHOPI group and other underrepresented groups. And it would also be interesting to perform a longitudinal study tracking the EDSS trajectory over 5 to 10 years in patients with baseline spinal MRIs, so that we can truly assess the prognostic significance of early spinal lesion burden. And lastly, because MS commonly presents with depression, anxiety, cognitive dysfunction, and even psychotic features, studying early spinal lesion burden across these ethnoculture groups is